Millions of people are treating the wrong problem. They feel the burn, they reach for a pill, and they think the story ends there. But what's actually happening inside your esophagus, and what those pills are quietly doing to your brain, is something almost nobody is talking about. Welcome to Andreessen Cole, where we follow the evidence and we don't flinch from what it shows us. Let's start with what GERD actually is, because most people only understand the surface. Gastroesophageal reflux disease, GERD, is the chronic, repeated backflow of stomach contents upward into the esophagus. Your stomach is built to handle caustic acid. It has a thick, specialized lining evolved over millions of years specifically for that job. Your esophagus, the tube connecting your throat to your stomach, is not built for that. It has a far thinner, more vulnerable lining. So when acid hits it repeatedly, it doesn't just cause discomfort, it causes damage. Real, measurable, cellular level tissue destruction. Now here's where it gets interesting, and here's your first open loop, because this is something most doctors don't explain clearly. The nerve pathways that carry pain signals from your esophagus travel to the same processing center in the brain as the nerve pathways from your heart. The same center, which means your brain often genuinely cannot tell the difference between esophageal inflammation and cardiac pain. This isn't a quirk or a rare oddity. Surgeons who've worked in this field for decades have noted that a substantial portion of patients presenting with what felt like angina, crushing chest pressure, left shoulder ache, even pain radiating down the left arm, were actually experiencing severe acid reflux. And the reverse is true too. Patients treated for reflux symptoms were sometimes actually dealing with heart pain. The overlap is real, clinically significant, and dangerously underappreciated. So if you've ever felt that tightness in your chest after a heavy meal, and your mind immediately went to your heart, you're not being dramatic. Your nervous system is genuinely confused. And that confusion has very real consequences for how we diagnose and treat this condition. Now, why does reflux happen in the first place? Let's go to the mechanism, because understanding this changes everything about how you approach the solution. At the base of your esophagus, where it meets the stomach, there is a muscular ring called the lower esophageal sphincter. Think of it as a one-way pressure valve, a gatekeeping structure whose entire job is to open when you swallow food down and then seal shut to prevent anything from traveling back up. When this valve is functioning correctly, stomach acid stays in the stomach. The system works. You're protected. But here's the problem. Certain inputs can weaken that valve. Not permanently, not structurally, but functionally. Temporarily, the sphincter loses its tone, its ability to maintain that tight seal. And when that happens, even normal digestive pressure can push stomach contents upward into the esophagus. What are those inputs? Alcohol is one of the most potent. Even modest amounts of alcohol can reduce lower esophageal sphincter pressure significantly. Chocolate, yes. The compound theobromine in chocolate has a direct sphincter relaxing effect. Spicy foods, particularly those high in capsaicin, are another major trigger. These aren't random associations. There are actual physiological mechanisms behind each of these. The sphincter doesn't fail randomly. It fails because of what we put in our bodies. Now, occasional reflux, a one-off event after a heavy meal, isn't going to cause long-term damage. Your body has some capacity to manage brief acid exposure and recover. But chronic reflux, the kind that happens night after night, meal after meal, that's where the tissue destruction compounds. That's where we move from discomfort into disease. And it gets worse than just the esophagus. If reflux is severe enough and persistent enough, stomach contents don't just stop partway up. During sleep, when you're horizontal and your body's natural gravity-based defenses are reduced, acid can travel all the way up the esophagus and spill into the airways. into the lungs. This is not a rare edge case. Many people living with what they believe is a chronic respiratory problem, a persistent nighttime cough, unexplained hoarseness, morning throat clearing that never resolves, are actually suffering the effects of nighttime acid aspiration. They may not feel the burn in the traditional sense, but the damage is accumulating quietly, deep in tissue they can't see or feel directly. This is educational, not medical advice. We're evidence-led here, and we manage risk carefully. But what we can tell you is what the science shows, and the science is unambiguous on the damage chronic reflux causes. So what do we do about it? Let's talk real interventions, starting with the ones that cost nothing and work faster than most people expect. The first and most powerful lever is dietary. Remove the inputs that are causing the sphincter to lose its tone. Eliminate or significantly reduce alcohol, chocolate, and high capsaicin foods. For a very large percentage of people, this single intervention produces dramatic symptom relief. Not gradual, slow improvement, dramatic. Because the sphincter hasn't been structurally damaged, it's been functionally weakened by repeated chemical insults. Remove those insults, the tone returns, the valve seals, the reflux stops. Simple, powerful, often overlooked because we'd rather take a pill. But diet isn't the only lever. There's a mechanical component here that most people don't think about, and it relates directly to something we talk about constantly in metabolic health: visceral fat. Here's the mechanism. Excess fat stored in the abdominal cavity creates pressure, intra-abdominal pressure. That pressure presses upward on the stomach, compressing it, reducing its capacity to expand after eating, and critically, overwhelming the lower esophageal sphincter, even when it's functioning reasonably well. The sphincter is a muscle. It has a strength limit. If the pressure pushing against it from below is high enough, it loses, and acid goes up. This is why one of the most reliable outcomes when someone begins reducing visceral fat is that their GERD improves or disappears entirely. Not because we treated their esophagus, because we relieved the mechanical pressure on the system. We lowered the load. The sphincter no longer has to fight as hard, and it wins again. Now watch this, because the positional fix we're about to talk about is something you can implement tonight, and it has real physiological logic behind it. The anatomy of your stomach matters here. The point where the esophagus connects to the stomach, the gastroesophageal junction, sits on the right side of the stomach. So when you sleep on your right side, you are essentially positioning the opening of your esophagus directly at the lowest point of the stomach. Gravity does the rest. Stomach contents pool right at the entrance to the esophagus. It's a direct, open pathway for reflux to occur all night. Now flip that. Sleep on your left side. The gastroesophageal junction is now positioned higher than the stomach contents. Gravity is working for you, not against you. The liquid in your stomach pools away from the esophageal opening. Reflux becomes significantly harder. A simple positional shift, no drugs, no cost, produces measurable reduction in nighttime acid exposure. Sleep on your left side. This matters. Elevating the head of the bed also helps, and the key word there is head. Not folding the bed at the waist. That actually increases abdominal pressure and makes reflux worse, not better. We're talking about tilting the entire bed frame so that the head end is physically higher. A 6 to 8 inch elevation creates a gravity gradient across the whole esophagus. That gradient slows or prevents acid travel upward during sleep. Traditional approaches involved literal blocks under the bed frame. Modern wedge pillows and adjustable bases accomplish the same thing more elegantly. The physics are the same. Now let's talk about where this gets serious, because we've been discussing discomfort and lifestyle management. But there's a trajectory here that most people don't think about until it's too late. Chronic, uncontrolled acid exposure doesn't just cause pain. Over time, it causes the cells lining the lower esophagus to change. The body's repair system, overwhelmed by repeated damage, begins replacing the normal esophageal lining with a different cell type, one that can better tolerate acid, but one that carries a significantly elevated risk of becoming cancerous. This condition is called Barrett's esophagus. It is a pre-malignant lesion, not cancer yet, but a lesion on a trajectory toward esophageal adenocarcinoma if the underlying damage continues. The conventional response to Barrett's esophagus, and to GERD more broadly, has been proton pump inhibitors, PPIs. These are some of the most widely prescribed medications on the planet. The theory was clean. Acid is the problem. Reduce acid. Problem solved. And in terms of symptom relief, they work. They're effective at reducing acid production. But here's where we need to follow the biology more carefully, because the story doesn't end with symptom relief. Stomach acid is not just an irritant. It is a critical biological defense system. Acid in the stomach serves as a first-line barrier against pathogens, harmful bacteria that enter the body through food and water. In a healthy acid environment, most of those pathogens are destroyed before they ever reach your intestines. Remove the acid, and that barrier collapses. The lower intestinal environment, where bacteria belong, suddenly has a pathway into the upper digestive tract, where they do not belong. The result? A condition called SIBO, small intestinal bacterial overgrowth. Bacteria that should remain in the colon migrate upward into the small intestine. Once there, they interfere with digestion, nutrient absorption, immune regulation, and gut barrier integrity. Bloating, pain, malabsorption, immune dysregulation, all of it downstream of a decision to suppress acid long-term without addressing the root cause. And research suggests that long-term PPI use is a significant contributor to the growing SIBO epidemic we're seeing clinically. But here's what should stop you cold, because this is the part of the PPI story that almost never makes it into a TV commercial. Proton pumps are not unique to the stomach. They are not a stomach-specific mechanism. Proton pumps are fundamental cellular machinery. They are how cells, particularly mitochondria, generate and manage energy. Mitochondria are the power stations of every cell in your body. They run on proton gradients. They need functional proton pumping to produce ATP, the usable energy currency that keeps every organ, every tissue, every system running. When you take a proton pump inhibitor, you are not selectively blocking proton pumps in your stomach. You are blocking proton pumps system-wide, including in your mitochondria, including in the mitochondria of your brain cells, which are among the most metabolically demanding cells in your entire body, packed with mitochondria, running at full capacity virtually every moment of every day. What does impaired mitochondrial function in brain tissue look like over time? Research has identified a significant association between long-term proton pump inhibitor use and increased risk of cognitive decline and dementia. This is not a theoretical concern. This is an association that has emerged from population-level data and is now being taken seriously in the research community. What happens in the stomach does not stay in the stomach. The downstream effects of interfering with fundamental cellular machinery travel everywhere the blood flows and everywhere mitochondria exist, and that's everywhere. So let's ask the real question. What if acid is actually a symptom here, not the root cause? Let's go back to something foundational, because this is the pivot point that changes everything. Your digestive system has evolved a finely tuned chemical environment for a reason. The stomach's acid environment, the carefully regulated pH of the small intestine, the bacterial ecosystem of the colon, these are not separate systems. They are one integrated defense and digestion architecture. When we disrupt one layer, we don't fix the system. We displace the problem and create new ones. So if the acid isn't really the origin story, what is? Consider the role of lectins. Lectins are proteins found in many common plant foods, particularly grains like corn and wheat, and legumes like soybeans. They are part of the plant's own defense system, designed by evolution to be irritating or harmful to organisms that eat them. In the human gut, lectins interact with the cells lining the intestinal and esophageal walls. They can disrupt the mucosal barrier, trigger inflammatory signaling, and interfere with normal digestive function. The mechanism is real. The gut responds to lectins with inflammation, and that inflammation contributes directly to the dysfunction we then label as reflux disease. The evidence for this isn't theoretical. Cattle fed high corn, high soybean diets, both extremely high lectin foods, develop severe acid damage to their esophageal lining. The agricultural industry's solution to this, historically, has been to add massive quantities of calcium carbonate, essentially the active ingredient in antacids, directly into the feed. Not to reduce lectins, not to change the diet, but to buffer the damage being done by continuing to feed a high lectin diet. Sound familiar? Because that is exactly what the conventional medical approach to GERD looks like. Symptom suppression without dietary correction. Buffer the damage instead of removing the cause. Here's what shifts the picture dramatically. Patients who eliminate or significantly reduce high lectin foods from their diet, not all of them, but the highest burden offenders, report dramatic reductions in reflux symptoms. Not slow, gradual improvement, rapid improvement, because the inflammatory trigger is gone. The esophageal lining, no longer under constant lectin-driven assault, begins to recover. The lower esophageal sphincter, no longer bathed in the inflammatory chemical environment that compromises its function, begins to respond normally again. And now the part that should make you think very carefully about the standard treatment approach, because this is where Barrett's esophagus re-enters the conversation. We've seen patients with biopsy-confirmed Barrett's esophagus, the pre-malignant lesion, the cellular changes driven by chronic acid damage, who were managed without proton pump inhibitors. Instead, they were placed on lectin reduction protocols, combined with visceral fat reduction strategies. And in a number of those cases, repeat biopsies showed resolution of the Barrett's changes. The abnormal cells reverted. The precancerous trajectory was interrupted. Now, and this is critical, this is not a guarantee. This is not a claim that dietary change cures precancerous lesions in every case. It doesn't. Individual biology varies enormously. Please work with your physician. Please continue the monitoring and treatment protocols your medical team recommends. What we're telling you is what the evidence suggests, that addressing the root biological inputs driving the damage can produce outcomes that pure acid suppression alone does not reliably produce. Mechanism matters. Root cause matters. If you're finding this useful, and we think you should be, this channel goes deep on exactly this kind of nutrition-disease intersection every single week. Hit subscribe. Don't miss what's coming next. Now here's a question we want you to sit with, because this drives right to the heart of it. How many people are currently managing a chronic inflammatory condition with a medication that simultaneously disrupts their gut ecosystem, compromises their cellular energy production, and carries an association with long-term brain function decline? And they don't know any of this? Drop your answer in the comments. We genuinely want to know. There's also a conversation worth having about the microbiome angle here, because it connects everything we've covered into one unified picture. Your gut microbiome, the vast ecosystem of bacteria that lines your intestinal tract, is not passive. It is an active immune regulatory system. The composition of that ecosystem directly influences inflammation levels throughout the body, including in the esophageal tissue. When the gut ecosystem is healthy, diverse, well-balanced, dominated by beneficial bacterial strains, it produces short-chain fatty acids and other compounds that regulate mucosal integrity, calm inflammatory signaling, and support the repair processes that protect tissues under stress. When the ecosystem is disrupted by chronic acid suppression, by high lectin dietary inputs, by visceral fat-driven metabolic inflammation, the balance tips. Pro-inflammatory bacterial species gain ground, protective species decline. The mucosal barrier, including in the esophagus, becomes more vulnerable. Inflammation becomes the default state rather than the exception. This is why the lectin reduction approach works through multiple simultaneous mechanisms. Removing lectin-heavy foods reduces direct mucosal irritation. It also shifts the gut environment in ways that support microbial diversity and mucosal healing. It reduces the inflammatory signaling that compromises sphincter function, and it supports visceral fat reduction over time, which lowers the mechanical pressure load on the entire system. These effects compound. They don't happen in isolation. The body responds as a system, not as a collection of separate organs. When we treat it as a system, when we address the inputs driving dysfunction rather than just buffering the outputs, we get results that drug-based symptom management rarely achieves. Now let's talk about the cases where surgery does enter the picture, because we want to be clear-eyed about the full spectrum here. There is a subset of patients for whom dietary optimization, positional changes, weight reduction, and microbiome support are not sufficient. Sometimes the reflux persists, and sometimes what's refluxing isn't even acid, it's bile. Bile reflux is a distinct problem, structurally different from acid reflux, and it doesn't respond to acid-reducing drugs because it isn't caused by acid. In those cases, surgical intervention, minimally invasive laparoscopic procedures that mechanically reinforce the lower esophageal sphincter, becomes a legitimate and often effective option. Surgery is a last resort, not a first resort, but it is a real tool. And for the right patient, at the right point in their clinical trajectory, it is the appropriate one. The goal is always to find the earliest effective intervention, the one furthest upstream in the causal chain. Dietary change is upstream. Positional sleep adjustment is upstream. Visceral fat reduction is upstream. These address the conditions that create the problem. Acid suppression is downstream. Surgery is further downstream still. The further downstream we go, the more we are managing consequences rather than eliminating causes. Which brings us to the final and most important thing we want you to take away from this. The conventional commercial framing of GERD, the ads, the over-the-counter solutions, the quick fix, is built around the idea that acid is the enemy and suppression is the answer. But acid is not the enemy. Acid is a signal. It's the body's response to an esophageal environment under assault. The question we should always be asking is, what is driving that assault? The answer, in the majority of cases, is a combination of dietary inputs that compromise sphincter integrity, inflammatory loads from high lectin foods that damage mucosal barriers, visceral fat pressure that mechanically overwhelms the system, and a disrupted gut ecosystem that can no longer regulate inflammation effectively. These are not mysteries. These are addressable biological realities. And addressing them doesn't require a lifetime of medication with cascading downstream effects on your gut health your mitochondrial function, and potentially your cognitive trajectory. Here's what we know with clarity. Reduce lectin burden, address visceral fat, support gut microbial diversity, optimize sleep positioning. These interventions work together. They address the biology at the level where change is actually possible. Here's what the evidence suggests: that for a meaningful subset of people, even established tissue changes like Barrett's esophagus may be reversible when the underlying inflammatory drivers are removed consistently and comprehensively. And here's the thing we want you to keep turning over in your mind: the open loop we're leaving you with deliberately. If chronic esophageal inflammation driven by dietary inputs is capable of producing precancerous cellular transformation in the esophagus, what else is the same low-grade, diet-driven inflammatory process doing to other tissues in your body right now? Tissues you can't see, can't feel, and won't think to check until the damage is already significant. That question has an answer, and it's one we're going to get into very soon.